Good afternoon, everyone, and welcome to today's Case in Point session. My name is Robert Byrne, and I'm an interventional cardiologist working in Dublin, Ireland. I'm delighted to be joined for today's session by two very experienced interventionalists, Farrel Hellig, who's joining from Johannesburg in South Africa, and Jack Tan, who is joining us from Singapore. Stefano Galli is the discussant. He's joining us from Milan, Italy. And Ralph Toelg is our chat master for today's session, who's joining us from Bad Segeberg in Germany. So the outline of today's session is to bring you through some challenging cases where devices with low profile have made a difference, where deliverability matters. And we're going to start with a case of small vessel treatment from Jack Tan, highlighting use of drug-coated balloon angioplasty. And then he's going to show us a couple of short cases towards the end of his presentation, in addition to the single long case. We'll have time for some discussion and Q&A. And then we're going to go to Farrel Hellig, who is presenting to us when seconds counts and focus on deliverability in the critical area of coronary perforations. Following that, we'll have further time for discussion before a sum up. The session objectives are to bring you through an interactive case session with interesting cases highlighting devices with enhanced deliverability in terms of DCB and covered stents, to assess where specific stents, drug-coated balloons or covered stents may be of use, and to give you some practical tips and tricks. So with those words of introduction, I'll now hand over and we'll have the first case from Jack Tan.
Thank you very much. My topic today is small vessel treatment. I'm presenting the use case of drug-coated balloons. My name is Jack from Singapore. These are my potential conflicts of interest. And the scope for my talk today, I want to discuss when is a drug-coated balloon actually preferred over the use of current generation drug-eluting stent or just a plain old balloon angioplasty. I also want to talk about the use case of when a DAS is definitely indicated over a drug-coated balloon. What is the best treatment strategy for small caliber coronary vessel disease? And I'll start that off by a case journey to illustrate the point. So my patient journey started in 2012. She was then a 46-year-old lady with the risk factors of diabetes, type 1, CKD stage 4 with an eGFR of 30. She was turned down for coronary artery bypass surgery because her distal targets was too poor for coronary artery bypass surgery. She had diffuse triple vessel disease. Her ejection fraction then was between 40 to 45%, and extremely poor Lima to distal LD target. So in 2012, I implanted drug-eluting stents in the proximal left anterior descending artery as well as the distal circumflex artery. Distal left anterior descending artery was then left alone. A total of 80 mils of contrast was used. And by 2019, her ejection fraction was 54% with no regional wall motion abnormalities. But 8 years later, in 2020, she presented with acute coronary syndrome. By then, she has gone down to CKD stage 5 and stage renal failure, requiring and started dialysis. Her ejection fraction dropped again to 42%. Then she had mid-LAD severe in-stent restenosis and progression of disease in the ostial circumflex, distal right, as well as distal LAD. My colleague then treated her with drug-coated balloon therapy with 3.0 and 2.5 DCBs in the proximal and mid segment of the LAD, but was unable to fully expand the calcified mid LAD segment. A 2.75 by 35 millimeter drug-eluting stent was implanted from the left main to the mid-circumflex artery. And this 54-year-old lady then, diabetic, end-stage renal failure, 8 years down from the first intervention, was turned down again by the coronary artery bypass surgery with a recurrent acute coronary syndrome. Now her ejection fraction has dropped to 20%. A 1.25 rotablator was then performed in the whole segment of the LAD down to the very distal LAD. The mid-LAD was then stented with a drug-eluting stent, and a plain old balloon angioplasty with a two-hole balloon was performed to the distal LAD. 3 weeks later, when she was brought back for a relook, there was diffuse in-stent restenosis of the distal LAD segment. The distal LAD segment was then treated with a 2.0 drug-coated balloon, and this is the final result without significant dissection of the distal LAD. 9 months later, however, for this patient, as you can see, in all the standard segments, she has diffuse in-stent restenosis in the osteocircumflex. She was then restented in the circumflex. However, as you can see, the distal LAD results remain decent and patent. She also had diffuse multiple in-stent restenosis portions in the right, as well as the circumflex. But I was quite impressed that the distal LAD remained patent. So a case pointer for this illustrative case is that the distal LAD location is really not a very good target for DAS implantation, as it forbids patients from future coronary artery bypass surgery. And a subgroup of patients with end-stage renal failure, diabetes, small caliber calcified disease, they often have poor results with drug-eluting stents implants. I think the best case used for drug-coated balloon is in-stent restenosis. For example, this patient with osteo left anterior descending artery in-stent restenosis in the left dominant system. This was treated with a 4.0 by 15 DCB after scoring with a 3.5 Scoreflex NC balloon. Another patient with osteocircumflex in-stent restenosis in the prior left main culotte stenting bifurcated segment. And the osteo LAD in this case was then again treated with a 4.0 DEB, osteocircumflex, sorry. And in this case, it negated the need to reimplant multiple stents in the previously stented bifurcation left main. The current technology, like the Pentarolux DCB, which is a paclitaxel eluting balloon, is currently the standard of care for most drug-eluting balloons. This current generation of balloon are actually very good deliverability with low crossing profile, as well as high crossability. I think the Pentarolux balloon is very equivalent and probably performs better in terms of crossability compared to current generation drug-eluting balloons. So what is a DCB? A DCB is, in my mind, 3 components: the balloon itself, the drug component, as well as the carrier. The Pentarolux is like the current standard of care drug-coated balloons coated with paclitaxel. The drug coating is equivalent to the rest at 3 microns per millimeter squared with a proprietary hydrophilic non-polymeric carrier. In the only smallish trial, the basket small 2, which evaluated and compared a paclitaxel drug-coated balloon to a second, third generation DAS, you see that at up to 12 months, major cardiac events, including death, non-fatal MI, and TBR, was fairly similar between the two groups, up to 365 days. But the main limitation for small vessel therapy for drug-coated balloons is a high rate of crossovers to stenting. But if they do get over the barrier of stenting, their results up to 3 years seems to be equivalent. We do have the highest grade evidence or data for in-stent restenosis in terms of drug-coated balloon, acquiring at least class 2B recommendation as alternate treatment in in-stent restenosis. In the largest meta-analysis recently published last year, the DALIS study, which looked at 10 randomized studies of paclitaxel coated randomized studies comparing to the current generation DES, we saw that in terms of target lesion revascularization, drug-eluting stent seems to perform better statistically compared to current generation paclitaxel-coated balloons. And you can see that event rate curves separate out at 12 months and during up to 3 years. But in terms of a composite endpoint of all-cause death, myocardial infarction, or target lesion thrombosis, there is no statistical difference between current generation paclitaxel drug-coated balloons versus DES, although there seems to be a slight trend towards the left side, favoring drug-coated balloons. Likewise, you see no statistical difference between the drug-coated balloon therapy for this combined safety endpoint. So in the Daedalus study led by Robert, you can see that in terms of primary efficacy outcomes of ischemia-driven target vessel revascularization, current generation drug-eluting stent still outperform drug-coated balloons. But you look at the combined primary safety outcomes of all-cause death, cardiac death, non-cardiac death, myocardial infarction, they seem to be neutral and maybe a bit leftward favoring drug-coated balloons up to 3 years. So my conclusion, drug-coated balloons may be better in bifurcated in-stent restenosis lesion, where you really do not want to lay more stent sandwiches, in simplifying bifurcated lesions in the side branch, which may be in the moderate size. In small vessels, in my mind, this will be vessels less than 2.5 millimeters. In the end-stage kidney disease patient, and maybe in the very long duration diabetic patients, where the TBR rates for stents remain high. Drug-coated balloons also may be worthwhile in locations where stents will limit future bypass options, like the distal LAD location. And drug-coated balloons currently still cannot overcome significant acute recall or flow-limiting dissections. So we do always have to bear that in mind when using drug-coated balloons. At the end, experience is required to maximize the use case of drug-coated balloons with excellent lesion pre-preparation, not having any geographical mismatch, and the appropriate acceptance of an end result. So with that, I'd like to thank you for this time and the opportunity to present this data. Thank you very much.
So, Jack, thanks very much for that clear didactic case, and then for the short cases at the end focusing on in-stent restenosis. And we'll open the presentation up now for some discussion. We have a number of minutes available for discussion. We look forward to hearing inputs from the chat master. Maybe I'll start with your first case, and I think, clinical practice guidelines would suggest here you have a 46-year-old patient, you have severe 3-vessel disease, you have diabetes mellitus, there's an indication, the slightly reduced pump function, and there seems to be an indication for revascularization. The guidelines would say surgical revascularization. Of course, the devil is in the detail. Surgical revascularization preferred, where the surgical risk is low and the anatomy is suitable. So here it's probably a good example of where the anatomy is not suitable. Particularly, you highlighted in your presentation the distal LAD. Any other thoughts on how you make those decisions together with your surgical colleagues when you're looking at the distal LAD? Are additional imaging modalities helpful?
So really the decision making is usually in the what we call the heart team decision at the CAF conference, where the case is actually presented, and our surgeons are not keen to do a stenotomy for any patient with 3-vessel disease that they can't realistically guarantee a long-term Lima result. So that's really the current limitation for bypass surgery. I think at the current data still strongly suggests that Lima will outlast any drug-eluting stents, and short of that, the surgeon typically will refuse offer of CABG for patients. And streaming back to Asia, this type of diffuse small caliber multivessel disease in the diabetic is more commonly seen in Asia as maybe compared to European countries. Thanks.
Mm-hmm. So, I mean, I think a pragmatic approach was taken back then to say, okay, let's do the proximal vessels in terms of the LAD and left circumflex and see what happens. And I suppose initially the patient stabilized, but then appeared 8 years later in a different condition with LV function significantly reduced. And then it's a different state of affairs. There was calcium modification necessary ultimately to resolve the stenosis in the mid-LAD. And then I suppose the approach is something that we're hearing more about nowadays, which is a hybrid approach, a combination of stents and drug-coated balloons. Stefano, would you like to come in there and tell us your experience of a hybrid approach in terms of a tailored therapy for a difficult case like this?
Yeah, it's a good case that shows Dr. Jack. And in my experience, in the novel lesion, in like the case like show in the proximal part until 3.2, 2.75, I believe that stent, if possible, is better. But in the mid-distal portion, especially in the diffuse in diabetics LAD, I believe that it's a good solution. But in my mind, in the novel lesion, in the proximal part, I prefer, if the good vessel like this, I prefer to fix with stent, and the distal portion with a drug elutine balloon. So in this case, for example, never I put a 2.2 stent because I don't believe, especially in the diabetics. I have only a question. Do you have any consideration regarding diffuse disease or different approach in diffuse disease in diabetic versus diffuse disease in non-diabetics in terms of lesion preparation or not, Dr. Jack?
I think lesion preparation is often neglected even when implanting drug-eluting stents. So I think good lesion preparation, like what was alluded to, if you have a calcified lesion, getting maximum stent expansion is very important for long-term results. So I think in the diffuse nature or diabetic lesions, you have to take the whole patient as a whole. So I don't really think about how to tackle a lesion, but how to talk about the vulnerable patient here. In the sense, in 2012, when she was approaching dialysis, the aim was not to get her into dialysis, not to overtreat, and to treat the systemic disease with statins and diabetic control, more so than implanting long segments of stents or DCB. So I think the take-home message then is good medical therapy, just treating the culprit lesion in subsets of patients like that. When the diffuse nature of disease tells me that even if you treat the epicardial lesions well, they will still have a poor outcome. So I think the take-home message is looking at the vulnerable patients.
Yeah, I mean, I think, Stefano, your point is well made. So we shouldn't forget, we say it every year in the case in point, that lesion preparation is critical to the success of drug-coated balloons. The drug-coated balloon is a device really for getting medication into the vessel wall. The other, and it's notable that many years down the line, calcium modification was used to deal with the problem in the mid-LAD definitively, and then the drug-coated balloon was passed. Because that's the second reason to do good lesion preparation with a drug-coated balloon. It's to reduce the dwell time to get to the lesion because the medication is washing off. Jack, do you want to tell us in terms of deliverability or what your thoughts are in terms of dwell time? Is it something that you measure? Do you say, okay, we're going into the Y connector now, let's see how long it takes us to get to the lesion? When do you stop and say we need to take out a balloon and give a new balloon?
So far, if you prep the lesions very well, deliverability for the pentarel lux balloon has not been an issue. So if you think you're going to challenge with deliverability, I think you haven't prepared the lesions as well as you should have. Yeah.
Stefano, did you want to come in there in terms of dwell time?
Yeah, I believe that in the especially in the diabetics, it's crucial to see very well the correct size of the vessel. Because if sometimes seems small, but really it's diffuse disease in this population. I believe that if you're not so sure, I believe that it's good to good images to see very well amount of plaque burden, and decide how to prepare very well, because it's different from the small vessel and the normal or big vessel diffuse disease. But I'm completely agree. It's crucial to prepare very well and the DCB only to deliver the drug.
Yeah, and I suppose sometimes a mother and child catheter will help, and we'll see it in the next case, but a mother and child catheter can often help if you've got a DCB, a long DCB that has to go to a distal vessel. This can help to reduce the dwell time. It's something we've started to measure in the cath lab, so we're used to documenting the times of our balloon inflations, and now we've started just to measure dwell time and say, let's make sure from opening the Y connector that we're getting the drug-coated balloon there in 30 seconds or less to make sure that we're not losing too much drug. Of course, we don't have studies to back it up, but it's probably something, if we're not measuring it, then we don't know whether or not we're doing a good job. So I'm going to thank you for your discussion there. I'm conscious that we need to stay on time, and we'll have further opportunities for discussion after Farrel's case. And at this stage, we're going to hand over to Farrel Hellig, and he's going to give us a presentation on when seconds count, focus on deliverability and coronary perforations.
Hello, everybody, and thank you very much for the opportunity to give this presentation. When seconds count, focus on deliverability in coronary perforations. My name is Farrel Hellig. I'm from Sunninghill Hospital, Johannesburg, and the University of Cape Town, South Africa. So what I would like to present is a patient who's a 57-year-old female. She's a type 2 diabetic and hypertensive and hypercholesterolemic with normal left ventricular function, as well as asymptomatic carotid artery stenosis. Her coronary artery history goes back 11 years, where she had stenting of the right coronary and in the mid-right coronary and the PDA and the circumflex artery. Her current problem is chronic stable angina for the past 1 year, which is now class 3 angina. She has angina during her daily activities despite medical therapy, which includes aspirin, clopidogrel, beta blocker, and antihypertensive medication, as well as medication for her diabetes. So on angiography, the left coronary does not demonstrate any stenosis, but the right coronary has a chronic total occlusion. And you can see the AP cranial projection, which demonstrates collaterals from left to right, corkscrew collaterals, and the occlusion of the right coronary, which I'll highlight in more detail. This is an LAO projection showing the retrograde filling in this dual injection and highlighting the CT of the right coronary. So what we see in the cranial projection was the proximal cap, which is an ambiguous cap with a side branch origin at the cap, and the distal cap in a very poor distal landing zone. And what I've highlighted on the right is the previous stent. There's a long stent in the mid-RCA as well as a distal stent in the PDA, which are demonstrated there. So this is a JCTO score of 3. The lesion had been attempted previously, and therefore antegrade Y escalation is unlikely to succeed. In the LAO projection, you can see this lesion is actually quite a long occlusion. You can see the proximal ambiguous cap, the distal cap, as well as these long stents. Retrograde access was not possible due to the corkscrew nature of all of the collaterals, and multiple septal channels were attempted, and these are terribly corkscrew and difficult to cross, and therefore an antegrade procedure was used. So the stent was entered with a Confianza Pro guide wire through a Turnpike LP microcatheter, and a Fielder XTA was then knuckled into the stent, and then a crossboss was advanced through the stent after delivering a 7 French trap liner, and you can see in the right-hand panel the crossboss advancing distally. Here you can see the crossboss is now in the distal true lumen and had crossed into the distal true lumen through the distal stent. and then balloon dilatation was performed. A 3 by 20 millimeter non-compliant balloon was chosen, and this was inflated at 12 atmospheres. And the unfortunate consequence of this pre-dilatation was perforation, which you can see in these two images in two different views. So these were the first injections which demonstrate where the perforation was. And in these still images, I've highlighted the perforation site in this LAO projection on the left and the epicranial projection on the right. And it seems very clear where the perforation is. It appears to be a clear target for how to solve this case. So there was a balloon inflated initially, the same balloon at lower pressure for 10 minutes, but the patient continued to bleed. And you can see here the accumulation of contrast in the right ventricle. But the patient continues to bleed after this 10-minute balloon inflation, and a PK papyrus 3 by 20 millimeter stent was then successfully delivered and carefully positioned over the area which we thought was the site of perforation. And you can see this was delivered through the previous stents and through the 7 French trap liner. Here, after delivering the stent, we still have ongoing bleeding. And it was difficult to understand this ongoing bleeding because I was quite convinced that the stent had been put in the correct place. So a second stent was placed a little more distal, another 3 by 15 millimeter papyrus at 18 atmospheres. But the patient continued to bleed. So post-dilatation was performed with a 3.25 by 15 millimeter non-compliant balloon to try and enlarge the covered stents up to 20 atmospheres, but bleeding still did not stop. So really not sure what to do now. The papyrus, another papyrus 3.5 by 20 millimeter stent was placed more proximally. And you can see here in these views that it's actually slightly more proximal to the site of the actual jet of contrast at the perforation. And this then successfully brought the bleeding under control. So you can see this in the case was then finished with an everolimus eluting stent 3 by 32 and 3 by 48 placed in the proximal segment to cover the proximal disease, and all post-dilated with a 3.25 millimeter NC balloon. And here you can see the bleeding is controlled, but there continues to be a large hematoma of the RV. But the RV hematoma did not compromise the patient. There was a small pericardial effusion that did not need drainage. The patient was discharged the following day, and at 6 months, the patient is well with no angina on dual antiplatelet therapy, which is planned to continue for a year. So what happened? The possible explanations could be a cobblestone effect, a lot of calcium outside the stent preventing good apposition. I don't think that's the case. Not too much calcium. More proximal perforation with tracking of the perforation parallel to the vessel and then exiting more distal. I also don't think this is the case. I think what happened is there was deep subintimal passage of the crossbars, creating a deep gutter, making a very, very wide vessel, and the covered stents could not reach this diameter, and therefore extending the stents proximally and distally covered to the areas outside of the gutter and solved the problem. And the features of the papyrus that resolved this problem were the ultrathin struts, the single stent design, and the thin membrane, polyurethane membrane on the abdominal side, and the expansibility of these stents. You can see that they can expand significantly and they can pass through small guide extensions. The stents were able to cross multiple previous stents. The overlap does not compromise the lumen as much as a AA stent, such as a Joe stent, and passage through a 7 French guide extension easily happened. And there was ability to pass the guide extension through these covered stents to facilitate delivery of additional stents. So the lessons learned is the role of imaging in perforation. Perhaps IVUS would have dictated a smaller initial balloon. The site of perforation may be difficult to identify, but multiple stents may be needed. But this is actually quite unusual. In the past perf registry published last year, of which I'm a co-author, 80% were treated with 1 stent, and only 3 stents were only needed in 1.4% of cases. So this is an unusual scenario. Success was high, 96% sealing. Deliverability of covered stents is therefore key to saving lives, and I think it's important to have a good range on the shelf to make sure you can deal with these sorts of unusual cases. Thank you.
Maybe move on to start with the discussion, and that's certainly a very interesting case, complex PCI that ultimately ends up in a perforation, which then needs to be addressed in a rapid manner. Can you take us through what your thought processes are in the cath lab when you see a major perforation? What steps are you immediately putting in place?
So the first thing I think is, thanks Rob, to take note of your perforation where it is, because once the contrast starts to accumulate, you may not get another opportunity to identify the site of perforation, because suddenly there's contrast everywhere. And so I think you need to, if you didn't do a cine run, you need to do a fluoro store when you first note the perforation to make sure you have something to refer back to. Then obviously you need to control the situation, and inflation of the balloon at lower pressure to tamponade the bleeding is the first step, and that often will give you enough time to decide on the next step, unless the perforation is in an area which prolonged inflation cannot be tolerated, such as the left main. But in a CTO context, it's normally fine to inflate for very long periods of time. And then you have to, prolonged balloon inflation may be adequate, but if you have to deliver a covered stent, then you have the option to deliver it through your existing guiding catheter, or get second access and get a parallel wire with a second guide catheter in order to make sure that you don't have downtime with your balloon. It depends on how much the downtime of the balloon can be tolerated. If the perforation is torrential, you really need to. But if you don't have downtime, if you have a little bit of time, like we had here, where the bleeding is not directly into the pericardium but more into the myocardium, then you can take more time to get your stents down. I think it's a pity that the slides weren't shown, because I was trying to, on the rest of my presentation, I was trying to demonstrate what I think was the problem here. And I think what happened is that the crossboss had a very extreme gutter, creating a deep subintimal tear, so that the stents could not get up to size, and you had to extend the area both proximally and distally to go into the more normal landing zones, to make sure there wasn't bleeding around the outside of the covered stents.
Yeah, no, I think that's a very good teaching point, and I know the slides didn't run, unfortunately, but I think we can tease it out here. So one of the crucial issues, I mean, you've talked us through the first steps, and by the way, many people will ask, do you give Protamine immediately? I think you told me that in your experience you normally wait because you're instrumenting the artery and you'd like to have some anticoagulation on board. I know some people will immediately reverse the heparin and say, listen, I'll take the risk, this is a life-threatening situation. And I think people's practices vary with regard to Protamine, but after the next step obviously is to try balloon tamponade, which you did. Now, how long do you wait? How long was your initial balloon tamponade in that case?
It was 10 minutes. I'd like to make a comment about the Protamine, though. I think the worst thing you can have is thrombosis in a bleeding patient. So I think that is an irresolvable situation. Mm-hmm. So I would really advise against giving Protamine until all your gear is removed from the artery. You can then give Protamine once you have no wires or balloons remaining in the vessel, and that's what we did. I think 10 minutes is the minimum amount of time for balloon tamponade to seal a perforation. You may need more than 10 minutes, but less than 10 minutes is unlikely to be effective.
Yeah. And so, I mean, you've had a go. It seems that it's still a significant perforation with ongoing bleeding, and then you go with a covered stent. You're alluding to it here, but sizing is crucial, and particularly where you've done anterior dissection and re-entry. I suppose at the point of the bleed, the vessel is now quite large. At least the gutter is quite deep. I think that's what you're getting at here as the main mechanistic explanation, is it?
Yes, what I think is that the subintimal space was way in the lumen of the vessel, and normally you sometimes in the CTO procedure will actually see a large subintimal space outside of the stented segment, beyond the stented segment. And sometimes those can remain, sometimes they can heal. But when the perforation is in that area, you won't get the stents up to size. So you have to extend the covered stent segment to reference areas, both proximal and distal, where it will create a complete seal throughout the area. And I think that's why we had to put both proximal and distal extensions to this covered stents in order to seal the perforation.
Mm-hmm. And interesting, I suppose, there wasn't tamponade, which can make management of the situation more difficult, I suppose, initially. Probably, like you said, there was some bleeding into the myocardium initially, and this resulted in rather delayed accumulation in the pericardial space, was it?
There was a little bit of pericardial fluid. And I think if we hadn't treated the bleed, there certainly would have been tamponade eventually. The accumulation of contrast into the myocardium was actually very rapid. It was quite a dramatic perforation. I just think, fortunately, it was on the myocardial side of the vessel and not the pericardial side, which did buy a little bit of time. But inevitably, that would have resulted in pericardial effusion if left untreated. I'm convinced of that.
Yeah. I suppose the mother and child catheter that you had in place, that was helpful when you're instrumenting where you're instrumenting.
Well, I think what was good about that is that the guide extension, and what's good about this stent being low profile, it's not like the dual layer Joe stent, which is very bulky and difficult to deliver. It's really a low profile device which could pass through the guide extensions, and in fact can pass through a 6 French guide extension, and can pass through pre-existing stents, and the guide extension could be delivered inside the firstly deployed covered stent to deliver a more distal one. So the stent does allow passage of guide extensions and stent through stent. So I think the low profile, if we hadn't had low profile devices, it would have been impossible to solve this case with a double layer covered stent.
Yeah. Jack, Stefano, in terms of your practice, obviously when this happens, this is a life-threatening situation. Any tips and tricks that we haven't touched on already?
So I thought the presentation was excellent by Farrel. I also couldn't get the mechanism, but a few tips and tricks I usually employ is the balloon tamponade is crucial once you recognize it, especially early recognition after you've done the initial balloon. Do a test part before removing the balloon completely. That helps with the rapid balloon re-tamponading. That's the time I also call for the echo and the pigtail if you do need to tap urgently for life-saving procedures. I do tend to do a quick squirt if I'm not too sure the location of perforation with the balloon tamponade up to make sure I'm not covering the wrong place if there's still leakage of dye proximally. The other thing I also a bit careful of is papyrus is a great covered stent, very deliverable. We will involve a guide extension, but sometimes you'll be careful about, because it's single layer and there's an overlap. If you overexpand, they can actually separate and it's not so clear. So I'm always a bit more generous in the overlap segment if you want to overexpand as well after that. In contrast to the Graft Master where it's dual layer, but the overlap covered area is actually even shorter from the stent edge. So knowing your covered stent does help when you do the overlap to prevent the geographical miss of covered areas. I don't still quite get the mechanism here. I agree with Farrel. It could be a dissection into the adventitia that continue to bleed due to a deep gutter between the two prior stents. That was a very good save, Farrel. Well done.
And Thanks for that, Jack. So in terms of the mechanism, I suppose, normally in this type of a case, you're using the crossbus to perform blunt dissection, and then you'll use, you'll switch strategy then to get re-entry into the distal vessel. In this case, you re-enter directly with the crossbus. Is that right?
Yeah, sometimes you get lucky with a crossbus. It can actually enter the distal true lumen. It can re-enter. And I think probably when it got to the distal stent, it will either go outside of the stent, or the stent would act as a sort of leverage point, and it levered inside the stent, which is pure good fortune, to be honest.
Mm-hmm.
But we were followed by some misfortune.
Yes, yeah. What do you think, Farrel, in terms of the long-term consequences? So it's a good save. It's a life-threatening complication. There's a lot of stent in the RCA. There's overlapping covered stents. Any thoughts about how you follow then this patient?
Well, I like to put a drug-eluting. If I'm putting an intentional covered stent, which is occasionally the case, I like to put a drug-eluting stent outside of it first to make sure I've got some drug. I know that's an anecdotal practice, but in this case, we've got just bare metal covered stent in that area, up to 3.25 millimeters. So the restenosis of that stent is somewhat unpredictable. I'm not sure. Clinically, the patient is well, but I think it may be worth relooking at this patient and doing OCT and assessing the results. But whether drug-eluting balloons will work in the context of covered stents is a debatable point. And putting another stent inside this multi-layered area is also of debatable value. So while the patient's clinically well, fingers crossed, restenosis won't develop. I think we should probably leave alone. Yeah.
And Farrel, maybe last point. Fail to prepare to fail. The covered stents, do you always have them in the lab when you're doing a CTO procedure? Are they in all of the labs, or do you wheel them in, particularly when you're doing a high-risk procedure?
We have a in our cath lab common storeroom where we keep all of the stock, and all the labs have access to that same storeroom. So we have covered stents on the shelf at all times. If I'm proctoring CTO elsewhere, I make sure that covered stents come along with me, that there are covered stents on site. But I actually think beyond CTO, covered stents are an essential thing to have on your shelf for general PCR, not only for CTO. Even though the perforation risk is high with CTO, it may happen with conventional PCR too. So I think covered stents are mandatory.
Yeah. Listen, Farrel, thanks for that. That was a great case, and I'm keeping an eye on the clock, and I think we're well advanced in the time, so I'm going to take a minute or two to sum up. I think we saw two great presentations today that highlighted issues around where deliverability matters. In the first presentation, we saw in particular complex anatomical disease pattern, and I think that was a situation where a tailored solution was the correct solution, and a hybrid approach with a long segment drug-coated balloon produced a good result. We talked a little bit about, if you're using drug-coated balloons, the importance of dwell time, the importance of lesion preparation, of being able to deliver your device as quickly as possible to avoid drug loss and have maximal efficacy. So I think there were some nice learnings from that case. The second case from Farrel, a very complex procedure. We know these complex procedures are associated with a higher risk of serious adverse events, and it's important to be prepared and have a bailout strategy. Equally important is to have appropriate deliverable equipment, and both of these steps are key in determining the outcome of the patient in this life-threatening situation. So with those take-home message, it remains for me to thank Jack Tan joining from Singapore, Farrel Hellig joining from Johannesburg, Stefano Galli joining from Milan. Thanks to you for tuning in. Thanks for your comments, moderated by Ralph Toelg, and enjoy the rest of the meeting. Bye-bye.
Bye-bye. Thanks, guys. Bye-bye.